This is a very common problem in our asthmatic patient, that they are very poor perceivers of symptoms. So in this very insightful study, which was published in JAPI 2015, this was done in Asia Pacific, and in this study, a lot of insightful facts came out. Is that 91% of our asthmatic perceive wrongly that their asthma is controlled. She's already on step 4 and 5 treatment. That is, she's on high dose inhaled corticosteroid plus LABA. LAMA is a long-acting antimuscarinic agent. She's on Montelukast and she's on oral corticosteroid. So she's already on step 5 of treatment. And so now, do you label this patient as severe asthma? You see your lung function test. The lung function test is very poor. His FEV1 is 29% only, and her FEV1 by FVC ratio is 33%. So there definitely is severe obstruction.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Today's topic is on severe asthma. So asthma being a very common condition, and we have seen that there is increasing incidence of asthma. And now with better diagnostic tools, we are able to assess it more precisely, the lung function as well as the type of inflammation, and we have assessment for the severity of the asthma and various treatable factors. And with the newer molecule developed, there have been a lot of research happening in how to differentiate between a severe asthma, uncontrolled asthma, difficult asthma, and how to change your approaches. I think what has happened with development of new molecules is that our approach towards assessing the patients of asthma who are not controlled has changed to a great extent. So even though you may not use these molecules, which maybe less than 5% of patient or even less, but with the whole attention to assessing the patients to actually detect which are the patients who really have severe asthma, I think our approach towards this patient has changed, and we have been identifying many treatable factors which is possible at even at a primary healthcare level to find out these treatable factors. And I think with that background, we'll enter into today's topic of severe asthma. So the outline of my talk is: how do you identify patients with severe asthma? What are the factors which lead to difficult or severe asthma, and how do you identify and address them? When you're treating a patient of asthma, you must set therapeutic goals, and you must monitor this patient frequently to find out whether you are reaching those therapeutic goals. And it is always better that you set these therapeutic goals in collaboration with your patient and the family. Okay, we're going to discuss algorithms to manage difficult asthma. How do you phenotype and endotype your patients of asthma so that you can give them individualized treatment and going towards precision medicine? What is the role of biologics? What has been our experience at our centers? And so we'll be discussing few cases also, so evidence and real life experience of using biologics in severe asthma. So how common is really severe asthma? So in your clinical practices, you must be noticing that patients of asthma, some of the patients of asthma, they do come with frequent symptoms or frequent exacerbation requiring some or the other intervention, or chronically they are uncontrolled, and over a period of time they kind of tend to tolerate their symptoms and they feel that's their normal. So patient of chronic asthma who's been on therapy for 10 years and who would have grade 2 dyspnea, even if at the age of 50-55, he would then consider that grade 2 dyspnea is kind of normal for him. This is a very common problem in our asthmatic patient, that they are very poor perceivers of symptoms. So in this very insightful study, which was published in JAPI 2015, this was done in Asia Pacific. This study was called Asia Pacific Asthma Insights and Management Study, AFM. And our own Dr. Sandeep Salvi was very much part of this study. And in this study, a lot of insightful facts came out. Is that 91% of our asthmatic perceive wrongly that their asthma is controlled. As I told you, a patient will having grade 2 dyspnea. Since he is having this symptom for such a long time, he thinks that is normal. And he'll report only if his dyspnea become grade 3. And this has been a very common scenario in patients from Asia Pacific region. 66% of asthmatic experience a frequent exacerbation every year. 42% make frequent emergency visits, and 64% of the patient, that means almost two-thirds of the patient, use their inhalers incorrectly. Okay, so either they use incorrect technique, or the compliance is poor. So these shows us the fact that all these are actually very, very treatable factors. And if little attention is taken to find out these factors and treat them, can actually prevent your patients from becoming severe asthmatic. So, what are the goals of the treatment? So this is very important that you, as a clinician, set the goal for your patient and make the patient understand that they don't have to settle for less. Asthma is actually completely controllable, though the patient would like to hear the word cure. The cure really doesn't happen because the tendency would not go away, but complete control or even becoming off inhaled medication is also possible. So you have to set these goals for your patients, and make them aware that all these goals are possible. So normal activity, health related quality of life, then preventing lung function decline, and that's very important. And for that, you need to frequently monitor the lung function, prevent adverse drug reaction related to medication, prevent exacerbation and hospitalization, and symptom control. Probably patient would be most interested in the first, last one, that is symptom control, and that's what they would perceive as normal control of asthma, and being able to do all the activities that they were doing before they got diagnosed with asthma. Okay, so these are the goals you need to set for your patients. Okay, now identifying severe uncontrolled asthma. So, how do you define uncontrolled asthma? So, if you have any one of the following, that is poor symptom control, if your patient is frequently symptomatic, that limits his activity or limits him from enjoying his normal life, that is poor symptom control. Patient gets frequent severe exacerbation, serious exacerbation which requires hospitalization, including ICU hospitalization, then airflow limitation. Sometimes we see that patients are symptomatically well controlled, but because of the ongoing inflammation, when you follow them with the regular monitoring of the lung functions, you find that they have airflow limitation despite of their symptom control. That's also included in uncontrolled asthma. And control asthma that worsens upon tapering of high dose inhaled corticosteroid or systemic corticosteroid. That means to be able to achieve the goal of good symptom control or prevention of exacerbation, you need to give this patient either high dose inhaled corticosteroid, that is budesonide equivalent of about 1200 to 1600 microgram, or fluticasone equivalent to 1000 microgram or more. So when you need this high dose inhaled corticosteroid or systemic corticosteroid to prevent them from getting any of these other complication, then that's also called uncontrolled asthma. Okay, and patients with severe uncontrolled asthma, despite GINA step 4 and 5, they are uncontrolled, then they are candidates for biologic therapy. Okay, so now what is the difference between difficult asthma and severe asthma? Now, this is very important, and many a times this assessment, if it's not done, you may end up introducing biologic at a much earlier, much early than it is required. So, patients, not all patients of difficult asthma would have severe asthma. The difference is that when a patient with difficult asthma, that is poor symptom control, decline in lung function, and all those things that we discussed previously, comes to you, you are supposed to identify the treatable traits in this patient. And if you identify this treatable trait, you address these treatable traits, and despite of that, a percentage of patient, a small percentage of patient, maybe less than 1% of this patient will still not get controlled after correcting all the treatable factors, and these are called severe asthma. So a small subset of patient of difficult asthma, maybe I would say up to 10%, would actually fall into category of severe asthma. So we discussed earlier poor symptom control. Then how do you assess the control? By objectively taking the asthma questionnaire or asthma control test. Frequent exacerbation requiring more than 2 courses of systemic corticosteroid in the previous year. Okay, and serious exacerbation, that is more than one hospitalization or ICU stay. And airflow limitation is when FEV1 is less than 80% and FEV1, the FEC ratio is less than 70%. Then patient is requiring high intensity treatment, that is high dose inhaled corticosteroid and systemic corticosteroids, more than 50% of the previous year. Now, severe asthma is a subset of patient when you have you have controlled all the treatable factors. Which are these treatable factors? These are adherence. Patient's adherence has been poor, or the inhaler technique was wrong, or patient was continuously exposed to triggers, or patient had comorbidities which were not addressed. And then these contribute towards uncontrolled asthma. So when you address all these factors and still your patient continues to be symptomatic or continues to have exacerbation or continues to need systemic corticosteroid, then these patients get classified as severe asthma. Okay. Now, how do you monitor? Now, see, to be able to identify your patients having severe asthma, you must have, monitoring parameters. So these may be clinical, monitoring their inflammation, making patient part of their, asthma care. So they self-monitor their disease and the lung function. So physician monitoring said, ask your patient to regularly follow up. And this is very important because most of our patients, we see that once they start feeling better, they feel that there's no need to go to the doctor. They feel that there's no need to, start taking medicines. And even now, so many of our patients would come to us after few years, sometimes, 2 years or 5 years. Or today only I had a patient who came to me after 13 years. And she just continued taking the medicine without any monitoring, without any clinical monitoring, without any lung function test. So it's very important that first time when patient comes to you, make kind of a, what's going to be the plan. And so in that plan, regular follow-up visits, regular compliance with the medication, and follow-up pulmonary function test at least once in a year is very important. So patients should be made aware that they should not disappear once they start feeling better. So regular follow-up visits, monitoring their symptoms every time they come. Every time they come, check inhaler technique and compliance. Like today, only one of my old asthmatic patient who has been following up with me for 10 years. And every time I write the medication, every time I explain to her, it come with exacerbation of symptoms and reveal to me only when I have problem of taking, problem, or only when I have symptoms, I'm taking inhaler. So I told her, I've explained you so many times, and I realized she's hard of hearing. So half the what I'm saying, she's not understood. She's 85 plus, she's hard of hearing. All these factors are also important to make sure that your patients have understood what you are saying. So, inhaler technique and compliance very important. Trigger exposure. Every time you must check that patient are exposed to triggers. You can have a checklist and you can tick mark. Okay, whether patient have got any treatment related adverse reaction, and objectively you check with asthma control test and asthma control questionnaire. So this on your part, you have to do it. If you have asthma counselor or junior, you have students or assistant, they should be trained to assess asthma patient with these set of parameters. And how do you check for the inflammation? You look for blood eosinophils. Any eosinophil count more than 300 is indicative of eosinophilic inflammation. You check for serum Ig level. You check for exhaled nitric oxide, FeNO test, and sputum eosinophils is done in very few centers. It is done in the research setting. Involve the patient in their own monitoring. So how they can monitor? They can check home PFR. They can keep their own symptom diary, and they can write down their triggers. Okay. Then lung functions, you must check every visit. You must check their peak flow meter. You must check their spirometry at least yearly, and impulse oscillometry can also be checked to look for. Sometimes spirometry is normal. Then for diagnosis, you can check their impulse oscillometry. And patients who are more advanced disease, you can check for their 6-minute walk test. Okay. So, how do you? I mean, these are the steps of asthma treatment. Step one is usually low dose inhaled corticosteroid only. Step two is low dose inhaled corticosteroids, and you may you may add leukotriene antagonist at this stage, leukotriene receptor antagonist at this stage. Step 3, if patient is still not controlled with step 2, then you give low dose ICS with LABA, or you give medium dose ICS with LABA. Step 4 is if patient is still not controlled with step 3, then you give them high dose or medium or high dose ICS with LABA, and you can add on other therapy like tiotropium and high tiotropium, and you can add derifylin or theophylline derivatives. Okay. So when the patient is not controlled, even with step 4 and 5, step 5 is that this is the time when you add on oral corticosteroids, and this is the time you consider biologics. The moment the patient starts to require in oral corticosteroids, then you consider biologics. So we have anti-IgE biologic, that is Omalizumab for severe allergic asthma, anti-IL-5 is Mepolizumab, Respiratory or Benralizumab for severe eosinophilic asthma. Okay. Okay. Now it's very important to understand the side effects of oral corticosteroids. Okay. Many of our patients are still very happy to take tablets, and they would be alarmed at meaning requiring to take inhaled corticosteroid for a long time. So you must explain. I think there's a chart you must always keep in your clinic, and all the multiple systemic side effects have to be explained to your patients. Side effect of oral corticosteroid, it can lead to hypertension, cardiovascular disease, metabolic disorders, which is very common. So many of our patients end up getting type 2 diabetes. Weight gain is one of the biggest issue, so leading to also obesity, going BMI more than 30, and that again leads to increased incidence of hypertension, diabetes, and cardiovascular complication, psychiatric disorders, psychosis, or even mood swings are very common with steroid. Early cataract. So many of our young patients who end up taking steroid for a long time develop cataract, dyspeptic disorder, osteoporosis. And many times we don't even regularly check our patients' BMD to find out an osteoporosis. Another complication which we see that avascular necrosis of femur, that's also very common. And not very common, but it's not so uncommon. And myopathies. Many patients who take Regular oral corticosteroid end up developing a loss of muscle mass and proximal myopathy. So all these multiple complications, and most importantly, increased susceptibility for developing infections. Okay, so these side effects have to be explained to the patient, and how much more safe it is to take inhaled corticosteroid for long term. So let us now come to a case discussion. She was a 51-year-old lady who was diagnosed with bronchial asthma since 10 years. She was following up with us in the OPD. On June 21, she came with worsening symptoms since 2 weeks, and worsening symptoms with dry cough and dyspnea on exertion grade 2 to 3. And she had several exacerbations in last 2 years, had required one hospitalization, which was a prolonged one. She's already on step 4 and 5 treatment. That is, she's on high dose inhaled corticosteroid plus LABA. LAMA is a long acting antimuscarinic agent. She's on Montelukast and she's on oral corticosteroid. So she's already on step 5 of treatment. And so now, do you label this patient as severe asthma? Just because she's symptomatic, she's already on step 5 therapy, would you really label this patient as severe asthma? And I think if audiences respond on chat box, that would be good. So, would you consider biologic in this patient? Now, further, we are using our checklist to assess the patient. She definitely is uncontrolled asthma, but whether she's severe asthma or not, we really need to find out whether it's just difficult asthma or it is severe asthma. So we found that she has chronic rhinosinusitis. She was taking inhalers without spacer. She was doing regular dusting at home. So even though she was atopic, she was doing so regular trigger exposure was there. Frequently, she defaulted on her inhalers. Recently, she had gained about 8 kgs of weight. Even increasing weight and obesity can predispose your patient to develop uncontrolled symptoms. She had uncontrolled diabetes. She was depressed because she had lost her husband and she's living alone. She had gastroesophageal reflux disease, so GERD was not addressed. So now, would you call this just a difficult asthma or severe asthma? So you found that there are a lot of unaddressed comorbidities. Inhaler technique is not correct, her compliance is not adequate, and she has all these other comorbidities. So comorbidities, inadequate inhaler intake, wrong technique, all these are factors which need to be corrected. So this is actually a case of difficult asthma and not severe asthma. We see your lung function test. The lung function test is very poor. Is FEV1 is 29% only, and her FEV1 by FVC ratio is 33%. So that definitely is severe obstruction. So this patient not only has difficult asthma, but is also going to develop. A patient has already developed COPD also. So severe irreversible obstruction. Then asthma control test was done, which score was 16 by 25. So any score less than 20 is indicative of uncontrolled asthma. 2D echo was done to rule out any cardiac comorbidity. HRCT scan chest showed hyperinflation. Her IG levels were 872, which is high. Eosinophil count was 1000 cells per ml. As I discussed earlier, any count more than 300 is considered of eosinophilic inflammation. Any count, serum IG levels is also suggestive of atopic inflammation. So we have two different type of patients who have just allergic asthma, where IG levels are high but eosinophil levels are normal. Patient who have eosinophilic asthma, where eosinophils are high but IG levels are normal. So that is eosinophilic asthma. Patient who have a combination of high IG as well as high eosinophil count. Now, this patient is falling into that category of having high IG levels as well as high eosinophil count. And the fourth subset of patient will have where they have more of neutrophilic inflammation. Okay, so this patient is fitting into atopic as well as eosinophilic inflammation. So after addressing all the risk factors, there was moderate improvement in patient symptoms. So this was not really a case for biologic; it's a case of difficult asthma. So how do you evaluate difficult to treat asthma patient for biology? First of all, you must diagnose whether it's difficult to treat asthma or severe asthma. Confirm the diagnosis and look for the contributing factors. Now, enough number of times we've discussed this, so you know all the contributing factors: inhaler technique, adherence, comorbidities, and overuse of SABA relievers, medication side effects. All that is considered into assessing the patient. Then optimize the management. Like what we did in this patient, she was definitely difficult to treat asthma. We found out all the contributing factors. We optimize the management. And then what you have to do after you optimize the management, review the response after 3 to 6 months. So if patient is not improving after addressing all the problems, then you assess this patient for severe asthma phenotype, and then you look for further management or further consideration for biologics. So difficult to treat versus severe asthma. The patient has symptoms: shortness of breath, cough, wheeze, chest tightness, not controlled by high dose inhaled therapy. Then symptom due to asthma. Okay. Then symptoms are due to asthma, symptoms in an asthmatic patient due to other causes. So not every patient of asthma having chest tightness or shortness of breath or cough, it's just because of inflammation. Many of these patients may be having GERD, and GERD also because of the reflux laryngeal irritation, and they can have all the symptoms which is mimic asthma symptoms. So that's very important. So symptoms due to asthma, symptoms in an asthmatic patient due to other causes, and respiratory symptoms in non-asthmatic. So patient may not have asthma at all and may have symptom which is mimicking like asthma. Simple GERD patient may have chest tightness, they may have, you know, irritation, they may have cough, sometimes they may also have wheezing. Patient in an asthmatic have co-association of GERD. The symptoms are getting worsened because of GERD and not because of ongoing inflammation. And the third category is symptoms due to asthma. Okay. Then you correct all the factors. Then you find out adherence, inhaler technique, whether there is airway inflammation or no. How do you find out? You look for blood eosinophil. If possible, you do sputum eosinophil. You check inhaled nitric oxide, and whether the symptoms are not due to inflammation but patient's lung functions are worsening. So we see a patient setup where IG is normal, eosinophils are normal, FeNO is also not high, but patient has got long-standing asthma and now going into fixed obstruction and developing COPD. So in that situation, your biologics are not going to help. Okay, so that is very important. So that you decide with use of spirometry. And then other thing which contribute towards asthma like or mimic asthma like symptoms is vocal cord dysfunction, which is very common in young female, laryngeal obstruction, GERD, anxiety. Patient may be deconditioned, patient is overweight, patient may have OSA. EDAG is a condition, excessive dynamic collapse of the airways. So excessive dynamic airway collapse. So that happens in patients with long-standing COPD. Tracheomalacia, COPD patient, bronchiectasis, heart failure. Now we need to do various investigation in this patient, like ENT evaluation, 24 hours pH monitoring for GERD. Sometimes you may have to refer your patient to psychiatrist. Do sleep study if patient has OSA. CT scan in inspiration and expiration will help you to identify EDAC, that is excessive dynamic collapse. Yeah. And clinical examination and for cardiac and NT-proBNP levels will rule out cardiac conditions. So in a patient of severe asthma, you have to consider from all these angles and then assess that patient whether patient has asthma which is purely because of ongoing inflammation. Okay. All right. Okay. So these are the different type of inflammation like we discussed earlier. This is severe allergic type phenotype, which is IgE mediated. Severe eosinophilic phenotype, which is mediated to the eosinophil with IL-4 and IL-5 are the main leukotrienes mediating this eosinophilic inflammation, and severe asthma with physiological impairment. That is, when you see the lung functions are declining, and these patients have severe neutrophilic phenotypes. Okay, so there will be a different approach. So if a patient has either eosinophilic or atopic, then if it's atopic, then apart from your inhaled corticosteroids, you need to give them anti-IgE biologic, that is Omalizumab. The patient has eosinophilic inflammation, we have Mepolizumab, Mepolizumab, and Benralizumab. If patient has got severe neutrophilic phenotype, currently we don't have biologic for them. Then in these patients, a long-term antibiotic use or addition of LAMA, some thermoplasty, all those things can be used in these patients. Okay, so it will be a different approach. So, what are the approved biologics available in India? Omalizumab was the first biologic to be available in India. So, moderate to severe persistent atopic asthma, which is not controlled by inhaled corticosteroid. It can be used about the age of 6 years. And what is the dose? 75 to 375 milligram subcute dose. It's usually weight dependent. You have to give either. So compared to Omalizumab and Mepolizumab, this is the advantage that the frequency of dosage is once in 2 months. Again, we have good experience by using this molecule, and we haven't seen major side effects. And none of the patient we had to actually discontinue medication for side effects. Discussing one more case, a 60-year-old female homemaker, known case of hypertension since 5 years. She had paroxysmal dyspnea since 15 years, and age of onset was 45 years. Diagnosed as bronchial asthma, increased symptoms since last 3 years. She was on inhalers, dry powder inhalers, and short course of oral steroid as and when needed. She was having frequent exacerbation, poor quality of life, and recurrent emergency department visit. So first pulmonology consult was done in 2019. So that time X-ray was done, which was normal. They found vitamin D deficiency. Inhalation technique was poor. She was shifted to MDI with spacer. The inhaler techniques was corrected. Her asthma control test score was very poor, 8 by 25. Anything less than 20 is indicative of uncontrolled asthma. PFR was 160 liters per minute. Again, that was very low. She was vaccinated. FEV1. FEV1 is just 60%, and the ratio is less than 70%. Okay, and it is reversible obstruction. In August 20, she developed moderate to severe COVID and requiring steroids and remdesivir and tocilizumab. She needed prolonged oxygen, could not take MDI, so she was shifted to nebulized medication, and prolonged course of oral steroid was required. September 20, HRCT showed that it was resolving COVID pneumonia. Her breathlessness increased, and she was considered for severe asthma workup. Serum Ig levels were 120, and FeNO was 12 ppm. Probably this is not really probably very reliable. Her adherence was checked, and caretaker daughter was counseled to give her proper medication. So she continued to require oral corticosteroid 5 milligram per day. So at this point, Mepolizumab was advised and started on her. And so once in a month, she used to receive 100 milligram of dose subcutaneously. She had significant improvement in symptom, frequency of exacerbation in pulmonary functions improved. Oral steroids were tapered off after 6 months, and after 2 years, she was given a break from Mepolizumab, and she continues to do well. So from February 21 to February 23, she received Mepolizumab, and now since past 2 years, she's off Mepolizumab and continues to take inhaled corticosteroid. and she continues to do well. Okay. So, just a little bit about this Benralizumab and comparing Benralizumab with Mepolizumab. It is anti-IL-5 receptor antagonist. Okay, now approved in India since almost 3-4 years now. It is indicated as an add-on maintenance treatment for severe asthma with an eosinophilic phenotype. Dosage, as I told you, first 3 doses we give once in a month, and then we give once in 2 months. So difference between it attaches to the receptor, there is more complete depletion of eosinophil with Medralizumab compared to Mepolizumab. Okay. So because it attaches to the receptor, there is near complete depletion of eosinophil. So blood eosinophil becomes zero. And from the tissues also, there is 96% depletion of eosinophils. So year 1, 2, and 3, here you can see in this study, the maximum 5 years data we have, and so far no safety concerns have been found. There is 63% reduction in the median dose of steroid, large number of patients getting off steroids, and significant reduction in the exacerbation. Okay. So this is the comparison. So they have not been compared. Head-to-head trial is not been there. That what was found that median OCS dose reduction in Benralizumab group happened in 75% of the patient, while for Mepolizumab it happened for 50% of the patient. 100% OCS elimination, that is completely off steroid, happened in 2/3 of the patient. That is 62% of patients receiving Benralizumab. There was complete omission of oral corticosteroid, while complete omission happened 14% in Mepolizumab. And OCS, oral corticosteroid reduction less than 5 milligram, happened in 80.6% of patients. So we have also seen some patients which are rightly selected who have not developed fixed obstruction coming off inhaled corticosteroid, oral corticosteroid, and even reduction in the dose of oral corticosteroid. We have one patient who is a doctor himself, a pediatrician. He had very bad nasal polyposis, severe rhinosinusitis, and uncontrolled asthma. And every time the trigger used to be rhinosinusitis. And he had undergone FES1, and after 3-4 years, he had recurrence of polyps and recurrence of rhinosinusitis symptoms. So his ENT surgeon had advised that FES need to be repeated, and the relapse cannot be, guaranteed that there won't be any relapse. And that point of time, he was introduced to Benralizumab. He started on Benralizumab, and his polyps went down. His rhinitis symptoms significantly came down. He was anosmic for such a long time, and he's got his sense of smell back, and he's now completely off nasal steroid. He is completely off oral steroids for past 1.5 years, 2 years he's been taking, and there has been no major exacerbation, no hospitalization. And now he's also cut down on the dose of inhaled corticosteroid. And we did his lung function, so lung functions are also maintained. So these are some of the patients who are super responder. So we have patients who are super responder, like this case, who will have all the parameters satisfied, like reduction in the exacerbation, reduction in completely stopping the oral corticosteroid, and reducing the dose of inhaled corticosteroid also. Then there are ones who partially respond. So there are partial responders, and few patients are non-responders. Okay. So this is a 7-step patient selection flow chart. So any patient you consider for biologic, you must follow this flow chart. This is first reconfirm the diagnosis, whether it is asthma or no. Many times patients come with the diagnosis, but have you documented any reversibility on spirometry, or at least reversibility on peak flow meter, or documented a wheezing, or improvement with inhaled corticosteroid and LABA, and history of atopy or what are the kind of inflammation. So that is very important. So first confirm the diagnosis. Step 2 is check adherence to prescribed therapy. And even now, more than 50% of your patient would cut down on their inhaler dose or even completely stop it. So every visit you check for the adherence. Rule out other causes of and comorbidity, as we've discussed many times in past few minutes. So you rule out all other comorbidities and other causes of worsening of symptom. Confirm that this is a case of severe asthma and not difficult asthma by addressing all the triggers, the adherence, technique, and comorbidities. Then look for biomarkers. So serum Ig levels, serum eosinophil levels, and if you have access, then you do sputum eosinophil. Then evaluate the patient for appropriate biology. Is it atopic asthma? Then you need Omalizumab. If it's eosinophilic asthma, then you can select either Benralizumab or Mepolizumab. If it's a combination of atopy plus atopy plus eosinophilic inflammation, then you have a choice of choosing either. So in that case, you generally prefer to use eosinophilic anti uh, anti IL-5, that is for eosinophilic severe asthma if they have combination, and if it's a neutrophilic asthma, then both are not going to work. So what is the appropriate biologic that you need to choose? And after putting the patient on biologic, you do evaluate with all the other parameters, clinical parameters, asthma control test, ACQ, do their spirometry, and all those, check their eosinophil and all, check their Ig levels. All those things you have to do it. So every 4 to 6 months you have to evaluate whether the patient are responding to your biologic or not. So whether they are super responder, partial responder, or non-responder. Okay, so take home message coming to last two of my slide. Goal setting and regular monitoring are the most important steps in management of asthma. Always, when your patient is not doing well, reconfirm the diagnosis, identify and address all the risk factors of uncontrolled asthma, and then you screen out real severe asthma patient. Okay. Phenotyping and endotyping is crucial for selecting the appropriate biologic. And type 2 T helper to response mediated through eosinophils and Ig and interleukins can be targeted through biologic. Omalizumab is for atopic asthma and Mepolizumab and Benralizumab for eosinophilic asthma, which are emerging biologics driving precision medicine for severe asthma. Thank you for your patient hearing, and I would be happy to take questions.
Thank you so much, ma'am, for that wonderful talk. We do have a lot of questions coming in from our doctors. I am going to be taking one of the earlier questions that we had. So the question is now on your screen. It is from Dr. Kulkarni. How do we manage status asthmaticus emergency if we are in a rural setup?
Okay. So, so if you are in a rural setup, yes, so medical management, I don't think would change much because these patients would require, first of all, nebulized bronchodilator is the most important because they have severe spasm, and injectable corticosteroids. So first thing when a patient of status asthmaticus come, to make the patient comfortable, start the patient on oxygen because they would be hypoxic, and to start the patient on oxygenation, give them a proper upright position, give nebulization. So usually we use salbutamol and ipratropium nebulization, can give them continuously till the time you get a breakthrough. And immediately injection hydrocortisone and methylprednisolone has to be given. Sometime in this patient you may have to give injectable theophylline derivatives also. Injectable magnesium sulfate can also be given. Okay, and shift the patient to intensive care unit. I think in the rural setting also now that is available. Patient can be put on NIV to reduce their discomfort, and I think time is very important in this patient. Okay, adequate hydration should be given because they have a lot of mucus plugging, they have severe bronchospasm, and they can get into respiratory fatigue and complication like pneumothorax or pneumomediasanum, or because of severe spasm loss, hypotension. All these are very common. So you have to manage that. You have to give it time continuously. You give in nebulized bronchodilators, and all these measures, most of the time patient would respond. A certain percentage of the patient who is not responding, becoming hypotensive, fatigue, and carbon dioxide levels are rising, then you might have to put this patient on ventilator. And it's a challenge managing this patient on ventilator. But when you have to ventilate this patient, you have to remember that they have got very prolonged expiration, and you need to put them on a very low respiratory rate. You have to give them a lower tidal volume to control the peak pressure, and you have to continue giving them nebulization through the endotracheal tube, and monitor for barotrauma like pneumothorax or pneumomediasanum can be used. Sometimes when you use ketamine or kind of anesthetic agent to relieve their spasm.
So, next question from Dr. Tripathi. What can be considered the best inhaler device for patients?
Yeah. So that is actually, the best inhaler device is, it has to be decided. There cannot be a set kind of prescription what is the best inhaler device. So it depends on what is patient age, what is patient's level of understanding, whether patient has got any other comorbidity, like elderly patient having shaking of hand and Parkinson's may not be able to use MDI. The cost factor is also important. The availability of the inhaler locally is also, and patient preference. So all these factors have to be taken under consideration. You have to give them a choice, whether they would prefer a DPI with a rotaheller, multiple other DPI devices are available with better quality and more efficient. Whether they would prefer to use a MDI, whether they would prefer to use a breath actuated device, or whether they'll be comfortable only with nebulizer. Okay, so you have to take into consideration all the factors and then deliver. And also, what are the patient's lung function? So you may want to give patient MDI, but the lung functions are very poor and we will not be able to take it on it. So you have to consider all these factors. And so if, for example, if a patient is a young executive who is very busy and cost may not be so important for him, he would prefer to take inhaler, which is like breath actuated. He doesn't have to put in the capsule, don't have to load it. So preloaded breath actuated devices may be preferred by these patients, and cost may not be so important for them. Time is more important. Okay? So this way, our elderly patient is there who may not be able to just learn the inhaler. So for them, nebulization may be a best choice. Okay? So these various things have to be considered.
So we had quite some questions on oscillometry. I'm addressing it together. What is the profile of oscillometry in status asthmatic?
Oh no, I think it's not a investigation of choice at all in status asthmatic. In status asthmatic, a patient may not be even able to do a peak flow meter, so that's out of question.
Taking the next question from Dr. Madhav, are there any tests to identify the allergens that are responsible for triggering the asthma?
Yes, very much. So you have some blood tests which are available. RAS test, it is called, where you can identify the allergen. Through history, you can identify the allergen, and the most reliable is a skin prick test. So you have the allergen available, and you do it the skin prick test with the control, and then you can identify. So till date, the most reliable way to find out is skin prick test, and always skin prick test or RAS test has to be aligned with the history. Now, many times you do skin prick test or you do blood test and you find the patient is allergic to a number of things. But patient says, oh, I've been taking that. I take peanuts and nothing happens to me. I take chana dal and nothing happens. So only if there is symptom by using that allergen or exposure to that allergen and matching with the skin prick test, then it is considered significant, and then you need to avoid those triggers, not otherwise.
So next question from Dr. Parvin. Can I give injection derifilin in IV in an acute attack? And also, what is the maximum dose?
Yeah, so see, these are medicines which can lead to arrhythmias, and that is the most important, especially if you are using in an elderly person who has got cardiac comorbidities, and if you give it very fast, a patient can have atrial fibrillation, severe tachycardia. So that is where even convulsions can happen. Okay, so usually nowadays we have almost stopped using injectable theophylline derivatives. Okay? Very rarely we give injectable doxyphylline or maybe slowly deripylline over 10 minutes if it has severe spasm. But I think by and large you should limit their use, and when you have to use it, limit the dose and and you have to give it over a long period. Either give it in an infusion or very slow deripylline injection you can.
So taking the next question from Dr. Arora. How long injection benralizumab be given every 2 months?
Yes. So, so far, what we have done in few of our patients, that minimum for 2 years we continue giving that. So, first 3 months you have to give it monthly, then we give once in 2 months. Okay. So, first year they get 7 doses, next year they get 6 doses, and then we have taken a break for these patients after 2 years of use. And so far, two of our patients who have been on the break after 2 years of use are doing well. And you have to keep on monitoring them. Suppose after few months or few years, it starts showing relapse of symptoms. And again, you have to do the same exercise again, rule out every possible other factor. And still, if they continue to have sin, then you might have to restart. But many of my colleagues also have given it for 2 years and given a holiday, and they are doing pretty okay.
Next, Dr. Devra asks, how does treatment of eosinophilic asthma differ from atopic asthma with high IgE antibody type?
So that we discussed that per se other factors would be same. In atopic asthma, sometimes when you do the skin prick test and blood test, you may be able to identify particular allergens. Okay? So then trigger avoidance may help a lot, or sometimes we can give also immunotherapy to them. When it comes to choosing biologics, a patient with allergic asthma with only atopic asthma, anti-IgE, that is Omalizumab, is a biologic which you have to use. When it comes to patient with eosinophilic asthma, then we have option of Mepolizumab or Benralizumab as biologic. Other treatment would remain same. So immunotherapy, trigger avoidance, and Omalizumab may be more helpful in atopic asthma, while Benralizumab and Mepolizumab more helpful in eosinophilic asthma.
Next, Dr. Rajput asks, DACC 100 mg thrice a day for 21 days adding, will it help with the regular treatment?
No, I didn't get the question. Can you repeat it?
DACC 100 mg thrice a day for 21 days, will it help with the regular treatment?
Which molecule you said? 100 milligram PD?
I'm not sure if doctor is talking about doxycycline.
Acibrophylline?
So, sir, if you could elaborate your question, we'll take it after taking the next
Your voice
question.
is breaking, Barka.
Yeah, am I audible now, ma'am?
Yeah, yeah. I think when this is shifting the earphone, that voice is becoming unclear. Yeah.
So, Dr. Rajput, are you talking about doxycycline? If you could just elaborate. Ma'am, we can come back to the question
Okay, okay.
once
We can
sir
go to the next
explains.
question.
Yeah. So, Dr. Jhansi asks, can only atopic induced wheeze is more prominent than shortness of breath, and that the wheeze is only relieved after inhalation of saba?
No, I don't think. I don't think you have any difference between atopy and eosinophilic asthma on that count. That account.
So another question from Dr. Devra is, how long do we give biologics? Do they cause lasting remission? Can asthma be cured by
Yeah,
any
so I
biologic?
told you that. Yeah, so 2 years is what we have used and given a drug holiday, and they have been doing okay. But all the research paper they have like given for 5 years, and they talk of giving it lifelong. But I don't think that will be very practical in India. So we have so far given it for 2 years and taken a drug holiday.
Another question we are getting quite a lot is, what is the cost of biologics like?
Yes, so it is definitely very costly. So if you have to use Benralizumab, the cost of one vial is it directly purchased from the company, I think about 1.8 lakh. For one vial, they give two vials free. Okay, so a yearly course comes to something like 3.6 lakhs. Okay, but nowadays, many mediclaim companies we've been able to procure, especially patient comes with increased symptoms and exacerbation, and we are able to give it during exacerbation also. So many of the mediclaims are honored when patient is able to procure the medication. So once they are hospitalized and they get the biologic, then they would get two dosages free. Okay, so that way they would be almost getting a year's course free. And certain like railways, ESIS, not railways and CGHS, they have it available in their panel. So you know, so I mean, the drug is available. So somebody who has got access to those routes can get it free.
Next question from Dr. Devra. How does FeNO help in assessing the severity of asthma and management of asthma?
What helps? How? FeNO.
Yeah.
So FeNO is basically for assessing airway inflammation. So any value above 50 part per million is considered significant of ongoing eosinophilic inflammation. So sometimes your spirometry may not be indicating, or patient who's got fixed obstruction, the spirometry may show no non-reversible fixed obstruction. And so then how do we define? I mean, how do you decide whether airway inflammation is present or not? So in this scenario, when you do FeNO, it tells us about airway inflammation and addressing the airway inflammation. Then once you initiate the patient on therapy and then you repeat FeNO and it comes down and you know that airway inflammation is come. So because sometimes Ig levels or eosinophil may remain high or may remain in one particular range, but may not give you exact reflection of what's happening in the airway. So FeNO will give you a reflection of what is the ongoing airway inflammation now.
Now we're getting quite some questions on adrenaline injection. So if we could comment on that.
Again, I mean, we just hardly use it now. Many times, when a patient of asthma comes, so we want patient to become spasm free. We want the patient to respond very well. I think that's not an indication for using adrenaline. Only in very severe cases where you don't have any other option. A younger patient, you may use this, when you feel that patient, you otherwise may lose your patient. But I think in last 5 years, I've not even single time I've used IV adrenaline. So you focus on your basic or nebulization, bronchodilator nebulization, your steroids, hydration, using NIV, magnesium sulfate. We also use this tuloplastin patch that is also helpful. So you use these measures, and most or almost all of your patient will respond. So we have hardly used adrenaline. If particular patient got anaphylactic reaction followed by bronchospasm, those subset of patient adrenaline may be useful.
So doctors, I hope that answers your questions on adrenaline. Next, I'm taking from Dr. Sunita. Can we treat steroid-resistant asthma with biologics?
Steroid.
Resistant asthma with biologics?
Yeah, so if they have eosinophilic inflammation or atopic inflammation, then we can. But if this steroid resistant asthma has got neutrophilic inflammation, then a steroid resistant is because so the type Th2 inflammation is not there. In all those cases, you will not be able to help with biologic.
So on similar lines, are there any precautions that has to be taken before initiating biologics?
So not really. I think we haven't really found any contraindication, and so far none of the patients we have had to stop. So no such safety concerns have been found. So and they also don't predispose like other biologic treatment, like for rheumatoid arthritis or you use for chemotherapy. So they don't predispose the individual for developing infection. So that is not the concern. So no such you know pre-evaluation or no such precautions are required.
So next from Dr. Agarwal, an asthmatic is controlled on inhalers and nebulization. Which one should be stopped first?
Nebulization, of course, because in nebulization you end up giving much more amount of medication. The absorption is much higher, and many times patients they get after they start getting better, they get bored of sitting for 15-20 minutes taking one nebulization. So invariably they start cutting off. Instead of twice, they will take once, and all those things they will do it. So always stop nebulization first. I mean, if patient is doing better, then nebulization should be stopped.
So, ma'am, I think we've answered most of the questions. Just taking the last two questions for tonight. From next is from Dr. Radha. How do we optimize an asthmatic coming for an emergency surgery?
Emergency surgery. Now this is again very important because many times and it's very common to keep on getting the references if you are working in a hospital. I don't know a patient is to be operated next day 8 o'clock in the morning or next day is to be operated and then ask for your fitness. So first of all, if surgery is emergency, then well, if that's life threatening or that's more important, you cannot because patient is asthmatic, you cannot just stop prevent them from undergoing surgery. What you can do is you can just check maybe a peak flow meter and check their symptom, give them injectable steroids. Okay, so that is the best way of start them on nebulized bronchodilator, nebulized steroid, give them injectable steroids, and if required, then explain to the patient that they may require NIV post-op, they may require prolonged ICU stay, observation. Also tell the anesthetist so always give hydrocortisone and inhaled bronchodilators and inhaled corticosteroid before 1 hour before the surgery, so that while inducing or while putting in the endotracheal tube, if it's a general anesthesia, they should not trigger bronchospasm. And you should be explaining to the patient that they may require prolonged ventilation, they may require prolonged ICU stay because they are in uncontrolled. But if it's an elective surgery, then definitely you should postpone the surgery, optimize the patient. If the patient is not controlled, optimize the patient and then subject them to surgery.
So, ma'am, taking the last question for tonight. It is from Dr. Ratan Deep. Does paracetamol precipitate bronchial asthma?
Thus, paracetamol?
Paracetamol precipitate.
No.
So I think, ma'am, we have covered most of the questions. Thank you once again for taking it very patiently. I'm very happy to let you know that we have more than 560 participants live for this session right now, and quite some good feedback coming in from our doctors in the comment box. So doctors really seem to have loved it. Thank you once again, ma'am, for this wonderful session. It was great
I'm so
having you back.
happy. I'm also very happy. Thank you for giving this opportunity, and I hope with this session, your treatment and management and assessment of asthma is going to improve, and we are going to prevent a lot of our patients going into severe asthma and requiring biologics. Now we have to prevent them from getting into a stage where they need biologic. Okay, and thank you so much to the audience for wonderful participation. Thank you.
Thank you, ma'am. Thank you once again. It was lovely having you, ma'am.